iris syndrome, managed by Morcher pupil expansion ring, with some problems. You can see that the pupil is not fully dilated, but at the same time it's not too small either. The problem is you can start with those cases with a good sized pupil, and you end up during the surgery that the pupil starts closing down on you, and you end up with problems with the iris prolapse, patches of iris atrophy, this kind of stuff. So I was thinking about, okay, not to use this ring during the procedure because the pupil is a little bigger than what we needed for with the small pupil, but at the same time I was afraid that it's gonna close down on me, so I thought, okay, well, I'll put the ring. The problem is that when the pupil is bigger than the ring itself, you have a problem of the ring staying in place, and that's what I'll show in this video here. The other problem is that if you don't use it, it's going to close down on you. So sometimes this is a situation where you can use the flexible iris retractors, because even if the pupil is big, it can still hold the pupil in place. Or the Mylugen ring, created by Boris Mylugen of Russia. This might be a little bit better than the Morcher pupil expansion ring for these cases, but I haven't used it personally, so I can't say how it's going to behave in those kind of cases. The other alternative, sometimes we put the diluted 10% phenylephrine. Put 7 drops of 10% phenylephrine, the preservative-free one, in a trabeculin syringe and completed with BSS so that it's diluted. I injected it at the beginning of the surgery, and it improves the IFIS a little during the procedure, but it works, but it's not that effective. It's still, you can see the IFIS, and you can see the iris prolapse and this kind of stuff. Here you can see that the edge of the ring is a little smaller than the pupil size, and it is as if we needed a bigger ring than this ring. Okay, probably flexible iris retractors would be a good option for this case, but I almost stopped using the flexible iris retractors once I switched to the Morcher, but I think for such a case it would be possible to use that. You can see that the ring now is free in the anterior chamber, and actually my chopper has actually pushed it out away from the pupil edge, so I'll have to just reposition that ring again in place. The good thing about the Mylugen ring is that it holds the pupil edge a little better than this, and it's easy to implant, as I've seen from the videos on this ring, but haven't used it again personally, so I'll probably do that in the future. We're just repositioning the ring. You can see that the pupil is getting a little smaller. I'll go in again to do the phaco. Okay, phaco's done. Again, the ring is trying to come off the position, actually pushed by the chopper. So it's not holding very well in place. J cannula can be used for cortical cleanup, can be used in cases of IFIS, but very cautiously. Don't push the fluid very hard with using high pressure, and keep an eye on the iris at the wound so that it doesn't prolapse. And you can push a little bit on the lip of the wound using the J cannula so that you don't build the high pressure inside the chamber that would push the iris out. So if you press a little bit on the wound lip, you create a patent wound, allowing the fluid to come out without actually increasing the pressure inside the eye and prolapsing the iris. So you can still use it cautiously, but if you forget that, you're going to end up with really big iris prolapse if you're not cautious. For these cases, I use it at a slow speed irrigation, so I frequently need maybe another syringe of BSS. That's what I did there. I put some more BSS into the cannula into the syringe. You can see that the cortical material is collecting, and it keeps on collecting like that, and all of a sudden it just comes out, all of it clean. And you actually clean the areas that you don't see. You can see that it's collecting more than sub-incision, and then it's gone. So this way, it's safely you can clean up the areas that you don't see to clean. And in using the IA at this stage under the blind areas, even the bimanual carries a little bit of risk of capturing the capsule. And I'll do a little more after the implant the lens. I'm preparing the lens now. This is a ZA 9003. The thickness with front guided lens, acrylic. You can see there's still some incisional cortex which I will clean in a second. You can see there's some iris prolapse happening. The cortical cleanup is completed, and it's time to remove the ring. You just dislodge the ring from the iris, and you can see that the pupil now is smaller than the ring, which would have happened without the ring during the procedure. You just need to depress with a second instrument, you depress the wound a little bit so that it doesn't capture the posterior lip of the wound while it's coming out. So depress it a little bit so that you can allow it to come out. You can see a very small patch of iris atrophy because during the procedure, probably even with the ring and the iris retractors, you still get a little bit of iris prolapse beside the irrigation, the aspiration tip. You can still get that. Cases of IFIS are the patients that sometimes have high post-op pressures, because a lot of times we are not able to clean the viscoelastic very well from the anterior chamber. Sometimes even cortical material can be hiding somewhere, so be careful with that. Try to just pass the irrigation around the anterior chamber to see if something comes out. And you can see that there's iris prolapse here, small one. Just trying to push it to very low pressure and hydrate the wound again. You can see this, the actual size of the pupil is now much smaller than what we started with. It's very deceiving, the IFIS, because it's you can start with a nice pupil and you end up with trouble during the surgery. Thank you for watching. Thanks.